This is Lieutenant Smith, and today I'll be discussing the drug atropine. Typically, atropine is supplied as atropine sulfate in sterile water in a 5 ml glass vial or as a pre-filled syringe called a mini-jet. In the 5 ml vial, it would be half a milligram in that 5 ml, and in the mini-jet, it would be 1 milligram per 10 ml. Each ml of injection contains 0.1 milligrams of atropine sulfate. The injection also contains things such as sodium chloride, sodium citrate, and citric acid monohydrate as preservatives. There are several applications for atropine during anesthesia. It can be used as a premedication in patients that need drying of secretions as an anti-salyagot. It can be used during the operative period to treat severe bradycardia. And lastly, during the reversal of anesthesia in combination with neostigmine, it is used to counter the effects of muscle relaxants. Atropine is an alkaloid, which is widely distributed in nature. It is found especially in the nightshade plant, Atropa belladonna. This drug is an anti-muscarinic agent. That means that it acts as a competitive antagonist on muscarinic receptors. It competes with acetylcholine to prevent coupling of G protein at the receptor sites on these receptors. Atropine causes dissociation of the G protein complex by changing the conformation of the receptor. Atropine is highly selective for the muscarinic receptors, yet does not distinguish among the M1, M2, and M3 subgroups as some other drugs in this class are highly selective for a particular subgroup. The M1 and M3 receptors are GQ protein linked. That means that they work by the mechanism of IP3 to DAG cascade. M2 receptors are GI protein linked. They work by inhibition of cyclic AMP production and activation of potassium channels. M1 and M3 receptors are GQ-coupled protein receptors. They are located on the neural tissue, glandular tissue, such as salivary and sweat glands, smooth muscle, and endothelium. When an M1, M3 agonist, such as acetylcholine, activates the GQ protein, it activates the phospholipase C pathway. Phospholipase C forms inositol triphosphate from phosphatidylinositol. IP3 stimulates the sarcoplasmic reticulum to release calcium. This calcium binds to calmodulin and in turn binds to myosin light chain kinase. This complex binds to myosin, which activates actin binding and leads to smooth muscle contraction. The effect of this contraction results in an increase in salivary secretions, pupillary constriction, and other effects of this system. Atropine, as a muscarinic blocker, inhibits the ACH from binding to the GQ receptors and leading to the effects such as decreased oral secretions or, in the eyes, dilation. In cardiac muscle, increasing adenyl cyclase results in cyclic AMP derived from ATP, which activates cyclic AMP-dependent protein kinase A. Protein kinase A phosphorylates the L-type voltage-gated calcium channels on the membrane, which results in an influx of calcium. This calcium is called the trigger calcium. The trigger calcium releases a greater amount of calcium from the sarcoplasmic reticulum into the cell's cytoplasm and binds with myosin, causing an increase in inotropy. Adenyl cyclase also opens the ion channels that are responsible for the pacemaker current in the sinoatrial node, leading to an increase in heart rate. Protein kinase A also phosphorylates myosin light chain kinase in the heart and contributes to an increase in inotropy. M2 receptors, which are found in cardiac muscle, are GI-coupled receptors. They have an inhibitory effect on the adenyl cyclase pathway and predominate in the heart. So ultimately, the stimulation of an M2 receptor by acetylcholine results in the inhibitory response of decreased heart rate and contractility. As previously stated, atropine functions as a muscarinic blocker and inhibits the GI receptors, resulting in inhibition of the inhibitor of the heart. That inhibition results in an increase in contractility and an increase in heart rate. When an action potential comes down the axon terminal and releases acetylcholine, it is ineffective because it is blocked by the atropine from working on the muscarinic receptors. And by this mechanism of action, the atropine prevents the usual action of the acetylcholine. This slide represents the different dosages for the various uses of atropine. Pre-medication is 0.2 milligrams to 0.6 milligrams. For intraoperative bradycardia, 0.4 milligrams to 0.6 milligrams could be given. As an adjunct in reversal, 0.015 to 0.03 milligrams per kilogram is given. Pediatric dosage is 0.01 milligrams per kilogram. And as an ACLS dose, of course, it is 1 milligram. Given by IV route, the typical onset of atropine is 45 to 60 seconds. Given IM, the typical onset peak effect would be around 30 minutes. Clinical duration after the IV route of administration is 1 to 2 hours. Plasma levels after intramuscular and intravenous injection are comparable after 1 hour. Atropine is widely distributed throughout the body and crosses the blood-brain barrier and placenta. Up to 50% of the dose is protein-bound. The half-life of atropine varies between 2 hours and 5 hours. This is the beta half-life, which is the time required for the drug to exit the body. Atropine is eliminated by being metabolized in the liver through the processes of oxidation and conjugation to inactive metabolites. 50% of the dose is eliminated in 4 hours and 90% in 24 hours. It is excreted via the urine with 30 to 50% as unchanged drug. Clinical aspects of atropine include the following. It is different from other drugs in the class because of its non-selective antimuscarinic effects. Peripheral effects of atropine include tachycardia, decreased production of saliva and sweat, bronchial, nasal, lacrimal, and gastric secretions. decreased intestinal motility, and inhibition of micturition. Atropine increases the sinus rate and sinoatrial and AV node conduction by blocking vagal tone. The heart rate is usually increased, but it is sometimes preceded by initial bradycardia, especially in small doses of atropine. The muscarinic receptor blockade effects of atropine results in inhibition of the parasympathetic nervous system. The tissues most sensitive to this drug are the salivary, bronchial, and sweat glands. Atropine inhibits secretions throughout the respiratory tract and relaxes bronchial smooth muscle, producing bronchodilation. Clinically, the muscarinic receptor blockade results in inhibition of parasympathetic nervous system effects. The most sensitive tissues to this drug are the salivary, bronchial, and sweat glands. Atropine inhibits secretions throughout the respiratory tract and relaxes bronchial smooth muscle, producing bronchodilation. The contraindications to atropine include cases of known hypersensitivity, prostatic hypertrophy, bladder neck obstruction, reflux esophagitis, unstable cardiac rhythm, narrow angle glaucoma, and myasthenia gravis. It is also contraindicated in severe ulcerative colitis, toxic megacolon, obstructive disease of the GI tract, paralytic ileus, or intestinal atony. There are relative and absolute contraindications for the use of atropine. It is contraindicated in cases of known hypersensitivity, prostatic hypertrophy, bladder neck obstruction, reflux esophagitis, unstable cardiac rhythm, narrow angle glaucoma, and myasthenia gravis. It is also contraindicated in severe ulcerative colitis, toxic megacolon, obstructive disease of the GI tract, paralytic ileus, or intestinal atony. Concerns when administering atropine include children and the elderly, hyperthyroidism, hepatic or renal disease, hypertension, also febrile patients, tachyarrhythmias, congestive heart failure, or contraindications for atropine. Relative contraindications or concerns regarding atropine include children and the elderly. Also in cases of hyperthyroidism, hepatic and renal disease, or hypertension. Febrile patients, tachyarrhythmias, congestive heart failure, and coronary artery disease are also cases of concern, but not absolute contraindications.